Hello, everyone, and welcome to today's webinar, Making the Connection, Improving the Relationship Between Shelters and Health Centers. My name is Julia Dobbins, and I will be the moderator for today's webinar, presented by the National Healthcare for the Homeless Council as part of our spring virtual training, with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation with the last 15 minutes reserved for Q&A. There is a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation during the Q&A session. Remaining questions will be logged and provided to the presenter for written responses after the webinar. If you're having any technical issues, you may also call the Council's office at 615-226-2292. This session is accredited for one continuing medical education credit hour through Vanderbilt University Medical Center. If you plan on claiming credit, please copy the information located in the CME Information's Note Pod at the end of the session, and then follow the instructions. The text and code will only be available during this session. Our presenter today is Cindy Manginelli, our TennCare Shelter Enrollment Project Coordinator here at the National Healthcare for the Homeless Council. Cindy, take it away.
Great, thanks Julia. I'm going to click here through the learning objectives and we'll look at those for just a moment. As Julia said, I'm the TennCare Shelter Enrollment Project Coordinator, and that's a mouthful, and we're going to talk specifically about our project and what we do here in a few minutes. But first I want to kind of look at the nature of this relationship between shelters and clinics and why sometimes that relationship can be problematic. And so what our project does to address those issues and what you may be able to do as well through your program. So when we're looking at shelters and clinics, we're talking about two groups of people who are really passionate about the same thing, and that is helping people who are experiencing homelessness. They're serving the same people with the same passion, so they have a lot of the same goals in mind, but fundamentally, these two groups have different priorities, and I think it's important to realize that when you think about forming a relationship, that while many of your goals are the same, and while you definitely care about the same group of people, at the end of the day, your number one priorities are different. And a shelter's number one priority is usually going to be twofold. One is that an emergency shelter is designed to do just that, to get people off the street and to provide emergency shelter, to get someone in a bed as opposed to under a bridge or on the street. And their second goal is almost always going to be housing, and very often that is mandated by their funders. You know, if they receive federal funds, that's definitely mandated. So their number one goal is housing and to get someone housed, and typically they have a pretty firm deadline in which to do that, sometimes 40 days, sometimes 90 days, but not a lot of time. And then clinics, again, passionate about the same group of people, but with very different priorities, and their priorities are often let's improve the quality of life, let's prolong life through medical care. And so I think everyone agrees these are all awesome priorities, but they can at times seem to be in conflict. If you're a shelter case manager, and I worked in a shelter for several years, and I worked in a detox unit and a drug rehabilitation center for people who were homeless or uninsured, and you know, our number one priority was housing, and we would very often think, and maybe not say out loud, but I think when it came to health care, there was an underlying sense of, let's just get you housed and then we'll get that health care taken care of. Let's get you in housing and then those things will fall into place. And very often on the other end of the spectrum, a clinic's perspective, and I worked in a clinic for the uninsured for years, and our perspective there was very different, was, okay, now that you're in a shelter and you have a little bit of stability and you're a little easier to get in touch with, and maybe you have help with transportation, you know, now that you have this level of stability and you normally don't, let's look at your health. Let's do some assessments. Let's schedule some of these appointments. Let's get these medical regimens in place. You know, let's do this now. And so sometimes there can be a conflict of interest there, even though everyone's really trying to help those who are experiencing poverty. So I think it's important to realize while we all are serving the same people, we're not always on the exact same page. So So let's look at some of those barriers to health in a shelter. And if you've never been to a homeless shelter, some of these will be common sense. If you're trying to serve those who are homeless and make relationships with the shelter, I would strongly encourage you to tour one or to spend as much time in one as you can just to get an idea of sort of the environment that your clients are coming from and that the staff you're trying to reach out to are coming from. But some obvious barriers to health in a shelter include cramped living conditions, a lack of privacy, inability to maintain hygiene, obviously lots of exposure to disease, but really the underlying problem being that you have a community of people who are living in crisis. You have a whole bunch of people living together who are all experiencing profound loss and almost all living with trauma. And so that's going to create a certain kind of environment. You can imagine, walking into the waiting room, into your waiting room of your clinic or walking into an emergency department. What would it be like to live with all the people in that waiting room? What would it be like to live in community with them? And that's sort of what a shelter is like to the extreme. And often there's a real lack of resources to afford for proper nutrition and hydration and personal hygiene products. And it can be really easy on the clinic end to look at your clients and go, wow, you have sandwiches every day for lunch, and they only give you 2 meals a day, or maybe you eat fried food every meal, and you can't even take a shower every day if you want to. And it can be really easy to look at all that and be critical and then think, wow, that's terrible. But you have to keep in mind that, again, the number one priority of most of these shelters, and that is to get people off the street. So I might be able to take 10 people and get them off the street and give them their own room and a bed and a private bathroom and 3 warm, healthy meals a day. Or I might be able to take 50 people or 300 people and give them a bed. And so these are the kinds of decisions that these shelters are making every day, is what is our goal, what is our mission, and how do we do that with the funds we have available to us? And so sometimes what seems like, wow, it's just common sense that you should be able to use the shower whenever you want, or it's just common sense that the meals should be more nutritionally based. You have to keep in mind, again, that the primary goal is getting people off the street and is providing a bed to as many people as possible. And so for that reason, sometimes things that we would consider to be necessities are not distributed and are not prioritized. Another big problem as far as health and shelters goes is there's almost always a segregation between residents and staff. So you have this kitchen and bathroom that are only used by the people in trauma, in crisis, that are only used by the people in poverty. And then you have another kitchen and bathroom that are used, exclusively by the people who are stable and the people who have access to resources, and never do the two meet. And so sometimes that too, you may have clients complain about conditions that staff, don't even regularly see because they're just restrooms and kitchens they don't go into unless absolutely necessary. And so that segregation, can contribute, can be a barrier to health. And then we talked about really how just the mission, the priorities there are different and sometimes inadvertently don't help to create a healthy atmosphere. So let's talk about barriers to health care in a community living environment, in a shelter environment. One is a real lack of training among staff, and it's important to remember that often shelters are staffed by people with very little experience and probably almost no clinical experience. In many shelters, a high school diploma is adequate, and many shelters will employ people who have come through their shelter system, and there's a lot of advantages to that, and there are some disadvantages to that. But to look at your shelter staff and say, it should be common sense that you would, and fill in the blank, that this is unhealthy and this is healthy. That may not be true. Your shelter staff just may not have that kind of training. I remember working in a clinic and seeing, when you work in a clinic, of course, sometimes you see a patient walk in and you look at them and you immediately know, wow, this patient's dying. This patient's really sick. And how did the shelter overlook that? And why are they just now seeing me? And why weren't they sent to the emergency room? And you got to keep in mind that when you're in a homeless shelter, you see a lot of people who look really sick, and you get very accustomed to seeing people who are just not well. And seeing people who are in psychosis is almost an everyday event. And so you get kind of immune to that, and what you see doesn't really startle you anymore. And you walk into a shelter, and almost everyone seems to have some sort of upper respiratory issue, and almost everyone looks, has poor color and looks depressed, and so you just have to keep that in mind when you think about working with shelter staff, that they're seeing almost everyone they're seeing on some level is unwell, and so they can miss someone who's really, really sick and should have been brought in earlier. You also, most shelters will have a policy that says we don't require our residents to seek medical care, and so unless someone's life is clearly in danger, or they're doing something that makes them a threat to themselves or others, we don't force people to go to the doctor. We may not even ask them to go to the doctor. We don't, that's sort of a, taboo issue in a lot of shelters by policy, is that we're not going to meddle in that. So a lot of times you see people who are really sick, and you can't say, hey, do you think you should go to the doctor? Would you like me to call an ambulance? Because it's just not allowed. So we talked about how the priority there of housing first means that health is not a priority, and that it may actually mean that that shelters intentionally overlook certain issues, just hoping to get the person housed first. In most shelters, there's a real inability to regulate medications or needed medical care. And what I mean by that is, with so many clients, or even just a few, that's not their area of expertise. So I know in many shelters, again, they're not allowed to say, hey, have you taken your medication? Do you think you need to check your blood sugar? That then becomes a liability issue, and they're really not allowed to comment on that at all. And so, again, to assume that a shelter is going to take those steps or watch for those kinds of things is probably a false assumption. And in a lot of shelters and a lot of programs like this, there is sort of an unspoken, ignorance is bliss kind of philosophy, or a don't ask, don't tell. And that can exist between the clients and the staff of a homeless shelter. If I'm a client walking into a shelter, I may know if they see my insulin needles, if they see my CPAP machine, if they see my blood pressure cuff, they're going to think I'm really sick. They're going to think there's something really wrong with me, and they're going to say I'm out of their scope, and I'm going to lose my bed. So I intentionally keep that from the shelter staff. On the other end, as a shelter staff member, I may look at someone and go, if I ask them what's going on with this wound, or what happened here, if I ask that and they tell me a lot of information, I'm now liable for this information. And can we really care for that? Is that really something we're equipped to do? And I may have to ask them to leave. And so there can be sort of this dance of, I don't want to know what's going on there, and if you don't tell me, I don't have to know, and then I'm not liable for that, and we're all just able to live together. Some housing programs have certain criteria where maybe you have to have a disability, or you have to have a chronic condition. And so sometimes shelter staff will ask questions so that I can get that one diagnosis that I need to know about, but I don't find out about other health issues that would actually disqualify you from housing. So it's a bit of a dance there, and sometimes you don't dig because I don't want to find out that you have a condition that's going to disqualify you from a certain housing program, or even disqualify you from our shelter. And so there may be really good reasons why the shelter staff don't find out all of that at intake, and don't get information that from a clinic standpoint would be considered vital. Having said all that, though, I find that most shelters are really eager to receive outreach and assistance from clinics. And we're going to talk about what's helpful and what's not in that regard. But shelter staff understand that that their clients are unhealthy, and that that's a problem, and that even though they may not have the ability or the time or the energy to delve into that fully, they do understand that there's a need there, and for some clients, a life-saving need. Poor health keeps consumers from reaching their goals, and it keeps case managers from reaching their goals. There's nothing worse than going in on a Monday morning and thinking, okay, we're going to go to the parole office, and we're going to get your child enrolled in school, and we're going to fill out that housing application, and walk in and realize you've got a fever of 104, and now everything's tabled. Case managers and ground level shelter staff feel that need significantly and want to know what to do and want to have a plan in place. Also, a healthy community living environment is obviously better for everyone, for the staff and the residents. No one wants to work in an environment that's unhealthy, where disease is allowed to run rampant and there's nothing we can do about it. That causes huge staff turnover in shelters. And so they are aware there's a problem and typically are very open to help. But what does that help look like? What's helpful and what is not? So again, we're with the TennCare Shelter Enrollment Project, and our project is a partnership between the Bureau of TennCare, which is what we call Medicaid in Tennessee, and the National Healthcare for the Homeless Council, and we're housed here in the main headquarters of the National Healthcare for the Homeless Council in Nashville, Tennessee. All of our work is here in the state of Tennessee. I'm hoping it will be applicable nationwide, but we are just local here in this state. So this is a specific project, but the kinds of things that I'm going to describe could really be done by any homeless health care center, or by any clinic wanting to do outreach, and by different, similarly minded agencies, and it would not be something that you need to have, a partnership with Medicaid in order to do. So these are the kinds of things we do. We have sort of a two-prong approach, and one is to assist consumers, and one is to assist shelter staff. And the real goal of our project is to ensure that clients who are eligible for Medicaid are able to enroll, and then that all clients are able to access services, in the field of healthcare and to get the healthcare that they need. So there are several different ways that we do that. One is that we assist consumers. We assist clients who are living in homeless shelters, as well as those who are in encampments. We primarily do that through Medicaid enrollment assistance. In the state of Tennessee, it's actually really tricky to get Medicaid. We're the only state that doesn't have a separate Medicaid portal. So you have to apply through the marketplace, and it's pretty complicated. So we do that. And then we provide trainings to consumers as well. We can do the Medicaid assistance, enrollment assistance one-on-one. We can also provide referrals one-on-one, but we'll do trainings. And we find that shelters are really eager to do this, to allow us to do this. Many shelters are required to collaborate with outside agencies and to bring in representatives from outside agencies. And so they're typically really eager to have someone come in and do a training because that usually helps them on a few different levels. So we'll do a 1-hour training, typically during a group time, which are already scheduled. Sometimes there are several a week that they have to do. But we'll come in for an hour or 45 minutes, and we'll just talk to residents about the basics of insurance, the very basics. What do you need to know in order to really take the first steps toward using your insurance? What's an insurance card? Things like that. And then we also provide resources for those who are uninsured. And Tennessee is not an expansion state. So we do have, honestly, a high number of residents that we meet with who are not eligible for Medicaid. In Tennessee, you're only eligible for Medicaid. For the most part, there are exceptions, but for the most part, if you have children or you are a child. So we become very familiar with all kinds of medical resources in various, in these communities, and we provide those resources to them as well. So what are some things to keep in mind as you think about doing that kind of direct outreach to people experiencing homelessness? The first one is to really remember, and this is common sense, but I think it's a good reminder, to remember the disorientation of homelessness. Just how hard it is to keep up with your insurance card when you don't have a place that's yours, when you're in a shelter where you have to lock all your stuff up in a locker, or maybe in a couple of different rooms, and where you may be asked to leave without much notice, and it may be difficult to go back and get your things, when you don't have, how difficult it is to make a doctor's appointment when you don't have regular phone service. So just to remember that, and to give the benefit of the doubt in all those things, because that just adds such a layer of complexity to life when so much of your mind is full of details like, what are we going to eat, where are we going to sleep, where's the dog going to go, things like that. Then we really tried to address the health concerns and priorities of those clients. And this is super important when you think about doing outreach directly into shelters, because I think as providers, sometimes we can really want to focus on those things that are truly life-altering or life-saving. You know, you look at someone and go, wow, if you could just change your diet, if you could just do a few things about your high blood pressure. And honestly, I find that the average consumer, that's just not what they're interested in hearing. We have a lot of people request, information on rashes and foot injuries and foot issues and things of that nature, and not really interested in, a diabetes screening and preventive care as much as this right here. This is what's keeping me from being able to focus on my immediate goals. This right here, this health issue is what's keeping me from feeling like I can focus on survival. And very often it's something like rashes or sexually transmitted diseases or birth control. So what is it that they want to hear about, and addressing those issues first? We do try to provide, especially for families, checklists and calendars and things, families that have open cases with the Department of Children's Services and things like that, where they've got to stay up to date on things or get back up to date. We find that something laminated that they can carry with them and check off is really helpful. We talk a lot about the difference between emergency care, preventive care, and primary care. And again, because Tennessee is not an expansion state, a lot of the clients that we work with seek 100% of their care at the emergency department. And as a result, a lot of emergency departments, get tired of seeing them and don't always provide the highest level of care. And so helping them to understand, especially if they've been uninsured for generations, the advantage of taking your child to the same provider and having developmental checks and things of that nature. And that really is new to a lot of the families and clients that we meet with. We discussed the value of documentation. What kind of paperwork do you just need to keep up with no matter what, and what kind of things can be discarded. And then we try to really challenge fears and misconceptions, the kinds of fears and misconceptions that keep people experiencing homelessness from going to the doctor, regardless of if transportation is provided and someone's there to help you make the appointment, those kind of nagging things that keep them from going anyway. And we're going to talk some more about a few of those in a few minutes. So those are some of the things, some of the services that we provide to people living in homeless shelters, and some of those services. Now let's talk about what we do with the staff. And this is sometimes the most important, because the staff are the people who are living with them, who see them every day, and who are really going to encourage them in their health. So the first question there is, when we talk about homeless shelter staff, who are we talking about? Who do you target? And this was something that we sort of learned in sort of a trial by fire, and sort of learned the hard way. We started off by thinking of executive leadership, and let's take the directors of these clinics and the directors of the shelters, and let's make sure they know each other, and let's build strong relationships there. And I think there's a lot of value in that. But at the end of the day, that wasn't extremely helpful for us. I think those introductions are important, but as far as maintaining relationship, we didn't see a whole lot of a ground level improvement when we started there. Because what we really needed to do is figure out, okay, when someone wakes up in a shelter and they're sick, who do they go to? Is it the receptionist? Is it a case manager? Is it an intern, sitting at a desk in the office? Who is it they go to? That's the person that we need to make a strong connection with. That's the person who needs to be connected with a similar staff member at the clinic. They need to know I can pick up the phone and call this person at this clinic, and they will help my client be seen. They will walk my client through the process. That's really, really important. Those are the people that you need to build relationships with. And so when we do trainings, those are the people that we target. And to be honest, they don't get invited to a lot of trainings. Your ground level shelter staff sometimes have never been to a training, and so they're usually really eager to come, really excited to be invited, and really eager to learn. So targeting that level and making sure those are the relationships that you're building, those are going to be the people who walk your clients through the referral process and either refer them or don't. So we do regional trainings throughout the state where we invite, again, that level of staff as well as executive staff from both the clinics and the shelters. We usually provide lunch. It's usually 2 or 3 hours and very informal. We try to make it a really fun training, and we bring those guys together. And that's where we talk about these relationships and what that looks like and what's helpful. And we also talk about what is a healthy community living environment, and then we talk about the health interests, that things that we know that will interest them. So we also will go to shelters, to individual shelters, and do training specific to that shelter. So if it's a domestic violence shelter, we'll do a training specific to victims of domestic violence or specific to unaccompanied youth. Whatever their demographic is, we'll also go in and provide trainings that specifically address the health care needs of those groups. And we're going to talk a little bit more about that in a few minutes as well. We do a helpline, which functions primarily right now as an email address. I found that to be much more helpful than an actual phone line, where they know you can email or call anytime. And within 24 hours, we're going to get back with you. So you have a patient whose Medicaid was canceled and you don't know why, a patient who can't find a dentist, whatever it is, you can email, and we're going to look that up for you, and we're going to help you with that. We do regular shelter visits just to stay in touch with staff, just to make sure that, just to strengthen that relationship. We do referrals, and we've talked about that. And then we also make very specific connections as needed. Sometimes it's not enough to say, well, there's a dentist down here, you should try them. Last couple of months ago, I had a shelter or a program in Memphis that was specifically for LGBTQ youth, and they called me, and I went to visit them, and they said, we can't find a doctor who will see our young people. They're not getting any medical care for anything. They're just really intimidated, and they've had really bad experiences. So I called a very specific person at a Memphis Health Center there, and actually had them meet one another. So now that youth center knows I can call this person at this clinic, and they will do what my youth need. They will make sure that my youth are treated well. And so sometimes making a very specific connection like that can be really helpful too. So as you do outreach to shelter staff, it's important to remember, as we said earlier, they have a huge rate of turnover. And so those connections have to be rebuilt and rebuilt and rebuilt, because sometimes, I've been here at the project for almost 3 years, and I'm almost dealing with a totally different group of shelter staff than when I started, just because there's such a high rate of turnover. We provide trainings that are appropriate for all staff levels, and so you want to really think about who's coming to this training and what is it that they do. And we open those up to volunteers and interns as well, because again, sometimes we find those are the people who are really making the referrals, or those are the people who are actually driving the clients to their appointments, and so they're the ones who need to know where the resources are. And just like we said with consumers, it's important that your trainings address their health concerns and their priorities. And any outreach that you do to shelter staff needs to be that way. Very often you'll see clinics come to a shelter and say, we'll come and we'll give everyone a flu shot, or we'll come and we'll do blood pressure checks on everyone. And sometimes there's not a real high interest there among consumers or among the staff. Across the board, when I try to make those initial connections between clinics and shelters, typically the number one request is, can they do lice treatments? Can they check everyone in in our shelter for lice, and can they treat them? And I don't have a whole lot of providers who are jumping at the chance to do lice checks, and there aren't many clinics that prioritize lice checks. You think here we've got all these people who probably have life-threatening illnesses, and we're going to take a whole day and treat lice. But for the shelter, if you have lice running through your shelter, that's devastating. That stops everything. Your employees quit, and people don't come to work, and it causes chaos. It's like bed bugs and scabies. These are the things that we get asked to do trainings on. These are the things that shelters ask us to find help with and to create partnerships for. And again, they're not going to be in the top probably 20 interests of clinics who are providing that outreach. But if you can start there and say, okay, sure, we're going to come in and we're going to address, this rash you've got going around, or this parasite you've got going around. And then there's room to build on that. But initially going in, if a shelter just feels like we are just devastated, with the scabies outbreak, and we don't know what to do, then that's really where you're going to have to start to build a strong relationship. And then understand the limitations of shelter staff, and those who work in any sort of assistance to those who are homeless, whether you're in a clinic or in a shelter. We're all really aware of our limitations, and I think any of us who sit down and spend time with someone who's experiencing homelessness get up from that conversation realizing there's only so much I can do, and I'm not going to be able to fix everything that's broken here, and I'm that heaviness of there's so much that needs to be done, and I can't possibly do it all. And shelter staff, just like clinic staff, feel that profoundly day in and day out. And so anytime you do any kind of outreach to shelter staff, I try to really make a point of being affirming and of really saying repeatedly, the work you do is hard, and that not everyone can do the work you do. And to make sure that you're not pointing out in any way, if you could just do this, if you just gave everybody this, to be very affirming and to just look at the resources they have and say, okay, what's the best we can do with this? How can we build from here? And then to really avoid medical jargon, to really avoid overcomplicating things, I find is a big mistake that we sometimes make, and that I've made certainly with shelter staff, is to get kind of bogged down in what are they going to be able to hear and remember and take back and apply? What are the most basic things that everyone needs to know and that they can go back and apply in their shelter? So now I want to talk about some special populations, some special groups of people who especially struggle to find medical care. And the first one is victims of domestic violence. And of course, there are many shelters that are specifically designated for victims of domestic violence. And wow, we could talk for an hour or for a day on all the ways that can complicate medical care. Of course, these shelters are typically confidential, so right off the bat, the patient isn't even allowed to tell you where he or she is staying, and that alone sometimes disqualifies people for care. If someone won't put, what their address is, right there, some clinics will reject them. So some important things to understand if you're going to really do outreach to a domestic violence shelter. First of all, medical issues are one of the primary reasons that people return to their abuser. And anyone who's worked in domestic violence will tell you this. I had many clients that, they packed up and they left shelter and they went home to their abuser because he had the inhaler or because she had the insurance card. And so as a provider, to look at someone who's coming out of domestic violence and say, well, just tell them they have to give it back, or just tell them they can't treat you that way. Those are words of someone who doesn't understand domestic violence. And and you're going to lose your patient and your relationship with a shelter by responding that way. You really have to understand the dynamic of a domestic violence relationship. But also, what are you going to do if a client comes in and says, yeah, I do have a prescription for that medication, and yeah, I've only taken 2 of the pills, but it's at home with my abuser. And we're not going to talk about solutions to all that now, but just that your program knows this is what we would do. This is how we deal with issues of health care for victims of domestic violence. What are you going to do if your patient doesn't have any documentation? Again, if they don't have their medication. How are you going to talk about that with your providers and your nurses? If you can go to a shelter and say, you know what, we realize that these are issues your clients may have. Here's how we're going to handle those situations. If you know for sure that you cannot see a client if she doesn't have Social Security numbers for her children, then you're not going to see her children. That's a firm policy for you. Then let the shelter know that, so they don't refer a client and she spends her whole day sitting there for no reason. Be really clear. This is the paperwork that your clients will have to fill out in our office. Some clinics that I've worked with even go a step further and say, you know what, you can go ahead and fill it out with them as their case manager and bring it. This is what we're going to do if a woman comes in and she's got a black eye. We are going to ask these questions. And so just kind of looking at those issues, what if you see a woman who's clearly been abused, are you going to assume that her children have been? Do you know which of your providers in your clinic handle those situations well and which do not? If you're sending outreach workers to a shelter, then it's really important that those outreach workers know these are the providers who handle domestic violence the way your shelter wants it to be handled. And these are the providers who really feel obligated that if they're sending a child to the hospital, they're going to call both parents and let them know, or whatever. Those are some of the situations that can arise. And the more clear you can be as a clinic, this is how we handle those situations, and let the shelter know that. The shelter knows what to expect, and they know what to expect when they send a client your way. As a case manager, as a shelter worker, if I send a client to your clinic and they have a bad experience, I'm not going to keep trying that. I don't have the time and the energy to say, well, maybe if I call them, maybe if we brainstorm together, I'm probably just going to go, okay, we're not going back there again. So being really clear on this is how we handle those kinds of situations. Similarly with unaccompanied youth, what are you going to do so that unaccompanied youth who come to your clinic feel welcome? And what if they are afraid of all authority figures? What if they're afraid of all the medical community? What if they don't have a guardian? If you know as a clinic we cannot see someone who's under 18 without a guardian, make sure the shelters know that. Or if we can see them, but we're going to need this, or we're going to ask these questions, make sure your shelter staff know that. Most shelters are going to be so excited about having a healthcare provider who says, here's the paperwork, here's exactly what the visit's going to be like, here's what they can expect, here's what we're going to do. Wow, that's going to be huge to be able to give that, that clear a path for their clients. And on the other end too, it's wonderful for clinics to know, all right, when we send a 15-year-old back to shelter, or we send a mom with 6 children who all have flu back to shelter, this is what the shelter is going to do with their prescriptions, with their diagnosis, and so having those kinds of conversations, is enormous, so that both groups know exactly what to expect and honestly know what not to expect. If you know this shelter is not going to do anything with them once they get back there on their own, that's good for you to know too. That's good for you to set really clear expectations. Okay, good questions to ask, especially for youth, but with all groups, is what medications are allowed in your shelter and what are not. We would very often have someone return to shelter from clinic with, give this medication, take it as needed. but medication had to be locked up and was only dispensed twice a day, so it couldn't be taken as needed. So to understand the rules and guidelines on both sides will help alleviate a lot of confusion and a lot of frustration. Another special population are those suffering from substance abuse disorder or mental illness. And, these are two groups who typically have so much lack of confidence in the medical community and so many bad experiences of being ignored and disregarded. And so this is another special group. If we send a client to you and they're in psychosis, are you going to feel obligated to have them, under what circumstances are you going to have a client committed against their will? And what's that going to look like? What are you going to do with the client who you really don't feel like can follow through? And just kind of same thing we talked about with the other special populations. Here's how we treat these clients. And so the shelter knows exactly what to expect, and then you as the clinic know exactly what to expect. So lastly, before we go to questions and answers, I want to talk about two unseen barriers to health and healthcare. And I always talk about these two in trainings that I do with shelter staff. Because these are, I find these to be just enormous barriers to health that you see almost across the board, and they're unspoken, and they're not always intuitive. And so the first one is chronic disease or chronic pain. And what I mean by that is you have a person who's experiencing homelessness, especially those who are chronically homeless, and at some point in their life, they receive a diagnosis. Bipolar, diabetes, whatever it is, you have this, and you're going to have it your whole life, and these are the things you have to do for the rest of your life to be healthy. And the client hears that diagnosis and either can't or won't manage that condition. And so for the rest of their life, whenever they get sick or depressed or anxious or whenever any sort of symptom arises, they attribute it to that diagnosis and do not seek care. Or they know that the healthcare provider is going to degrade them for not managing that condition, and so they don't seek care. So I have a bad cough, and I don't go to the doctor because I know my schizophrenia is not managed, and they're going to yell at me about that. Or I attribute it to schizophrenia on some level. Well, it's probably just because I haven't been taking care of that, whatever that big diagnosis is. It can be really helpful to understand that because a lot of times, so often we sit down with clients and whether it's on the clinic side or the shelter side, and we say, okay, here's your appointment, and here's your transportation, and here's how you're going to pay for it, and here's your documentation, and they don't go. And they don't go to the appointment. They don't go to the referral. And this is often one of those reasons why, is because they have some big diagnosis, and they feel like that disqualifies them from ever being healthy, or that disqualifies them from ever receiving care for anything because of that diagnosis. And then one other that I want to talk about. So this is Janice. I show Janice's picture in a lot of trainings that I do, but I showed Janice's picture to a room full of young women about her age about a year ago in Memphis, and I said, this is Janice, and she was living with her boyfriend, and he kicked her out, and they had a big fight, and now she's homeless, and she's staying in a shelter. She's been doing okay. She's gotten a job. She's looking for transitional housing. But this morning she woke up and she feels terrible. She feels awful. She's got a terrible headache and she's got a fever, and it's really bad. But Janice is not going to go to the doctor. Why do you think Janice is not going to go to the doctor? So I asked that to this group of young women in Memphis, and one of them raised their hand, and she said, because she's ashamed. And I thought, wow, that's okay, she's got a headache. I'm not sure what's she ashamed of. And the girl said, everything. And I really think that is the primary reason that people living in poverty or in crisis or in trauma or in homelessness do not seek health care. And I get a similar answer, anytime I do a training and I ask that question. I was in Knoxville last month and interviewed seven men who were homeless, all different backgrounds, all different stories, all different personalities. And one of the questions in the interview, it was like 150 questions, and one of them was, if you get sick, where will you go? And there was a homeless health center, a good homeless health center right across the street. I actually wrote down the answer before the first one said anything because I thought, I know they're going to say this clinic. And he said, every one of them said, I don't go anywhere. And I said, why not? And over, every answer was something to the effect of, no one cares, no one's going to listen to me, no one wants to see a homeless person, feelings of shame, feelings of worthlessness, feelings of hopelessness. And so understanding that, I think, and again, they're not necessarily going to say that when you say, why didn't you go to the appointment? Why don't you go to the clinic? Why didn't you tell your case manager at the shelter about your medicine? Why didn't you tell her? It's not necessarily something that's going to be verbalized, but that underlying feeling of shame and I'm not worth anything and no one cares. So as a shelter staff member, I've got this client that I'm investing in and I care about and I'm trying so hard to take care of. I want to send them to a clinic. Probably on some level, my most basic desire is to send them to a clinic and absolutely know that the front desk staff, the nurses, the pharmacists, the providers, that every person who sees and touches my client is going to love them, is going to take care of them, is going to extend grace to them, is going to listen to them, is going to foster trust in them. That's the main thing I want to know. Just like that's the main thing that clinic staff want to know as well. That's what's going to make me pick up the phone and make that referral. That's what's going to make me dig into that relationship is when I know this is going to be another support level for my client. This is going to be another way that they feel valued. This is going to be someone else they can turn to when they're not in my shelter anymore. So I think that is really the foundation of these relationships. That is really fundamentally what you need to keep in mind is allowing that shelter and assuring that shelter staff that while we are going to care for your clients and we care about you and we're going to listen to you, we believe the best in you, we don't criticize your shelter, we realize your limitations, we're on your side, we're going to lay aside new expectations, frustrations, things of that nature, and we're going to work together for the best of this client. All right, I'm going to turn it back over to Julia for any questions now.
Thank you so much, Cindy. This has been really interesting and informative and powerful. We really appreciate it. We do have a few questions that I want to get into, but first I just want to remind everybody that we do have the CME information available right now, so make sure you copy the code and also the instructions. The first question I have for you, Cindy, this is from Michael, and he asks, when shelter staff and health center staff begin to collaborate, how do you recommend they navigate HIPAA compliance when discussing specific clients?
Yeah, that's a big question. Typically, shelters are going to have a policy in place by which they do that. For some shelters, it's just going to be signing a release of information and a really well-written release of information. And then that's probably going to be something that has to take place on both sides. And it's going to have to be something that clients initiate. What I recommend is that, or what's ideal, is that relationship between there's sort of a memo of understanding, maybe even a formal memo of understanding between the shelter and the clinic, that we have this relationship and we know how we handle that in advance. Now that can't always happen, but that's the best case scenario. And so that otherwise it's on the client to initiate that very often, and the client has to say to the clinic, I want you to be able to talk to my case manager, so can I sign something? And then the client has to go to the case manager and say, I want you to be able to talk to my clinic. And then they have to sign something, and then both parties have to get together and fax that to each other. So ideally, that's something that that you would do with the clinic or with the shelter on the front end and say, okay, how are we going to share this information? And typically, the client will be allowed to be very specific about what kind of information is shared. Is it just information about my housing? Is it just information about my diagnosis, or is it just information about my appointment? My appointment times, or is it actual details of my case notes? And so the client, of course, gets to determine that and determine what that looks like. But if there's a really good relationship on the front end, then together you can determine what that looks like on a client-by-client basis.
Great. That sort of leads into the next question, which is for those who are working in shelter as frontline staff, who are listening in and interested in developing this relationship with the clinic, who would be the best person for them to reach out to at their local clinic?
Yeah, that's an excellent question. Sometimes and often a clinic will have a social worker, and sometimes that's a good place to start because often that social worker is also looking for referrals to shelters. And so a social worker is a really good place to start. If there's a behavioral health consultant, that's a really good place to start. And so ideally, those would probably be your best options. I know in some clinics that don't have either of those staff members, sometimes they'll have a care manager or a case manager who would be very interested in forming those kinds of relationships. What you're looking for is, okay, if I'm sitting in the doctor's office, in the provider's office, and I tell the provider that I'm homeless, who are they going to refer me to in the clinic, if anyone? Who are they going to send me to talk to? Is it a social worker? Is it a caseworker? Is it a behavioral health consultant? Who do they send people to for things like that? If none of that exists, then sometimes you would be looking at the medical director. Sometimes it would be the nursing director would be a good person to go to. And then sometimes, I just start with HR. And say, okay, who am I looking for here? We have people, with these kinds of specific needs, and we want to know who to refer them to. Who would be a good case? Who on your staff is that person to talk to? It's typically not going to do a lot of good, or not the best route to just call the front desk and say, I want to talk to someone about, having my homeless patient being seen. That's going to get you more just through the standard appointment trail. But if they have a social worker, if they have a caseworker, if they have a behavioral health specialist, someone like that's going to be a good place to start.
Great. And I think we just have one more question. What are some barriers that you have seen shelters and clinics face in developing their relationships?
Well, I listed several. Sometimes, honestly, the biggest barrier is just time and energy. And that again is if you're calling from a clinic, trying to establish that with a shelter is finding that person in the shelter who really has time to have that conversation. Most shelters, are living every day with the reality that they need a good clinic to send their clients to. But it's a matter of finding that right person who has the time to really build that relationship. So sometimes time and energy is the biggest one. I think a lot of times, sometimes you run into shelters that have very specific missions or very specific goals, and so they're looking, they don't want to partner with anyone who doesn't share those goals. You may have an organization that, is really focusing on, has a very specific faith-based goal or a very specific treatment-based goal. And so they don't want to partner with anyone unless they know you're going to reinforce our program and our project. So sometimes that's a barrier. So those are some common ones, but hopefully some of the things that we talked about today would help to overcome those.
Great. And I lied. We have one more question. This question comes from Karen, and she says, these populations can be transient and regular medical care is offered, but keeping visits with a particular PCP is a great challenge. We offer visits with other providers, but how would you suggest we best maintain regular care with one PCP when we're not set up as a clinic setting where patients just see any provider available?
Well, that is, obviously a huge issue, a huge problem, and that may be a little bit, out of the scope of what we're talking about here. If we're talking specifically about clients who are living in shelters, probably the best way to do that is to involve a middleman in the appointment-making process, and that's typically going to be the case manager. And so if you can somehow develop a system by which the client, who really struggles to keep appointments, the client who really struggles to remember who their PCP is, that client goes to their case manager, and the case manager assists with all of that. And the case manager sets up the appointment and helps them remember who that PCP is, and then arranges transportation, and that can be really helpful. A lot of managed care organizations do that, and they don't necessarily advertise that, but a lot of managed care organizations have what they call care managers or case managers. They have different names. But it might be worthwhile asking, your client, if your client is insured, to see if their MCO, their managed care organization, their insurance company, if you will, the company that gives them their insurance card, to call the number on their insurance card and say, do you have care coordinators? Do you have case managers? And sometimes, very often they do, and what those people will do is they'll sort of function like a medical case manager, and they will help those clients to remember, this is your PCP. No, remember, you've got to see this person, and they'll actually schedule the appointments for them, and they'll actually help them with transportation and walk them through that process. But looking for someone who can provide that sort of support to the client. It may be a family member. It may be a case manager with a different agency, but who can serve as that middleman to make sure that you see that when you call, you ask for the right provider, you even remember which clinic it is you go to, you get transportation, and you keep your appointment. But yeah, that is a huge issue, and so often an issue with this population.
We had another one come in, Cindy. This is from Veronica, and she asks, if I know a participant needs medical care, how can I convince him to go to the clinic? Sometimes I just don't want to go, and I don't know what I can do.
That is an excellent question. I would keep in mind some of these things that we just talked about here at the end, and that is saying things like, you're important to us, and we want you to take care of yourself. Obviously, you want to maintain good boundaries, and you don't want to, be inappropriate, but because very often that is the issue. Sometimes I'll say to clients, what's the worst thing that can happen here, and then try to get them to identify what are the fears that are keeping you from going. Trauma is triggered a lot of different ways, and sometimes just being in a small room alone, not wearing your own clothes, that alone is just terrifying to people. So if you can identify what is it here that's keeping you from going, and sometimes they know what that is, and sometimes they don't, but asking questions like that, what do you what's the worst thing that can happen? Or did you have something bad happen another time that you went? Or what if I went with you? Or what if, your roommate went with you? Or trying to figure out, because typically there is something that's keeping them from going. There is a reason. And if it's not, I just don't feel like I'm worth taking care of. Is it that's a trigger for you? Does it make you feel too vulnerable? Does it trigger addiction? Is that, something that's problematic? But what is it that's keeping you from going? And then what can we do to alleviate that? Is it possible to alleviate that? And sometimes you can talk with the clinic staff about that as well. My client really just needs to be able to stay fully dressed, or, when you go, please make sure with the client, this is all you look at, this is all you talk about. I find that a lot of people who are experiencing homelessness really fear and dread scrutiny, which makes perfect sense. Obviously no one plans to be homeless, so the idea of being scrutinized or being, looked at really closely is really intimidating or just really unpleasant. A lot of doctors, especially pediatricians, require that you answer, a whole lot of questions that have nothing to do with your physical symptom. So is it that? Is it just, that you don't want to be analyzed and looked at that closely? But if you can identify those what's the barrier, and then what can you do to alleviate that? Is it possible to alleviate it? And very often just having someone accompany them, if you can do that, will be enough to alleviate that. If they just absolutely won't go, then would they be willing to call a nurse's line? Would they be willing to do something over the phone? It's still better than nothing, often.
Great. Cindy, we have one more question, so we're going to make you work to the very last minute. So in 1 minute, can you recommend specific resources for good health practices for shelters?
I think our website, the National Healthcare for the Homeless Council, you're going to find specific things there. Very often, each state's own Medicaid agency, Tennessee has Insure Kids, and our Bureau of TennCare maintains a website, and I would imagine that most Medicaid agencies do. And so sometimes they will have on there a list of resources for people experiencing homelessness, and so that might be a good place to check as well. But our website, honestly, is probably going to be one of the best to look at and just to spend some time browsing through, and you're going to find all kinds of information on good health practices for the specific that are very specific to people experiencing homelessness.
Awesome. Thank you so much, Cindy. We have run out of time. If we didn't get to your questions, we will send them to Cindy for follow-up. And thank you to everyone for joining our webinar today. A link of the archived webinar will be available on our website at the conclusion of our spring virtual training. Please copy and follow the instructions to claim your CME credit for this session. The text and code will only be available now, and credit must be claimed within 24 hours. A survey will pop up in your browser at the close of the webinar, and we really appreciate your feedback. Thanks again so much for your time today. The webinar is now closed.